Welcome to Week 2, where we will be discussing the 5 phases of lung development. The first phase is the embryonal phase. The first 2 months of gestation. Lungs develop around 26 days after conception. Development of trachea and major bronchi. Complete development of diaphragm around 7 weeks. The next phase is the pseudoglandular phase. 7 to 16 weeks of gestation. Development of remaining conducting airways. Differentiation of the nasal cavity, oropharynx, and nasopharynx. The next phase is the canalicular phase. 17 to 26 weeks. Lungs become vascularized. Air-blood barrier is thin enough to support gas exchange. Alveoli begin to develop. Extrauterine viability 22 to 24 weeks. The next phase is the saccular phase. 26 to 36 weeks. Increased potential for gas exchange with the continued development of the alveoli. The next phase is the alveolar phase. 36 weeks to term, however, not easily distinguishable from the saccular phase. Maturation of the alveoli. This illustrates the embryonal stage of lung development. Trachea and major bronchi at 4 weeks through 8 weeks. As we examine the role of surfactant, we must look at surface tension. Similar molecules attract each other from all directions, like when you place a drop of water on the table and it beads. The molecules are being drawn together and inward, not being pulled outward by the air molecules. This forms surface tension, and this phenomenon also occurs in alveoli. The surface molecules of the alveoli, which are mostly made of water, are drawn inward to their smallest diameter. There is a lack of attraction by the gas molecules. This tension is determined by the thin liquid film that lines the outside of each alveolus. This film allows the alveolus to resist expansion. This film also squeezes the alveolus, producing recoil. A coating of pulmonary surfactant prevents the alveoli from collapsing from this surface tension. Insufficient pulmonary surfactant can produce newborn respiratory distress syndrome. To understand this phenomenon better, we will look at Laplace's law. As the radius of the alveoli decreases, the surface tension increases. As the alveoli become smaller during exhalation, much force is required to reopen them. To overcome this collapsing force, there must be something to reduce the amount of tension that develops. According to the law of Laplace, if 2 bubbles have the same surface tension, the smaller bubble will have higher pressure. Surfactant reduces surface tension. Pressure is equalized in the large and small bubbles. Surfactant lowers the surface tension. As the alveoli become smaller, the surfactant thickens on the alveolar surface, weakening surface tension. This prevents the alveoli from collapsing. Roles of surfactant: prevents movement of fluid into the alveolus and keeps lungs dry. Acts as an antiglue. Stimulates lung host defense system. Immunosuppresses. Acts as a chemotactic agent, opsonizes bacteria. Enhances mucus clearance. Formed by alveolar type 2 cells. Composed of phospholipids, neutral lipids, and proteins. Immature surfactant is seen around 24 weeks gestation. Mature surfactant is seen around 35 weeks. LS ratio. Listing to sphingomyelin ratio. Measurement of lung maturity. Lungs are considered mature when LS ratio is 2 to 1. LS ratio in amniotic fluid is used for the evaluation of fetal lung maturity. Prior to 34 weeks gestation, lysine and sphingomyelin concentrations are equal, but afterwards there is a marked increase in lysine concentration. A LS ratio of greater than 2 or greater than 5 indicates adequate fetal lung maturity. Delivery of a premature, low birth weight baby with low LS ratio 1 or less than 1 predisposes the child to respiratory distress syndrome. This graph illustrates the LS ratio in relation to the weeks of gestational age. The more mature the baby, the more mature the lungs. Fetal lung fluid. The fetal lung produces and secretes its own fluid. Low pH contains low concentrations of protein and bicarbonate, high concentrations of sodium and chloride. Maintains patency of the developing airways. Plays role in the formation, size, and shape of potential air spaces. A term lung is filled with 20 to 30 milliliters per kilograms of fluid. Total amount produced per day is 250 to 300 milliliters. During normal fetal breathing lung movement, about 15 milliliters of fetal lung fluid is moved from the lung through the trachea out the mouth and into the amniotic fluid or swallowed. Hazards of lung fluid retention. Often occurs in babies delivered by C-section. Phenomenon called transient tachypnea of the newborn TTN.
This figure illustrates the amount of fluid in the fetus compared to that in the newborn.
Transient tachypnea of the newborn. Caused by the delay of intrauterine pulmonary fluid. Normal respiration at birth. Mild respiratory distress at 4 to 6 hours. Peaks at 24 hours. Rapid recovery at 42 to 72 hours. Intubation not usually required. C-section or precipitous vaginal delivery are risk factors. Chest X-ray will follow the clinical course of respiratory distress, then clears with a normal chest X-ray by 48 to 72 hours. Chest X-ray demonstrates fluid overload with vascular congestion and small pleural effusions.